Good afternoon, everyone. Thank you very much for joining us for the next 75 minutes for this Edwards-sponsored session, From Repair to Replacement, a portfolio for your patients with mitral and tricuspid regurgitation. I'm Yiling Heng. I am very honored to be facilitating this session with Professor Philip Lertz, and will hopefully give you an agenda-packed session. Please do engage with us. The session's only what it's going to be if you participate with it, with your questions, thoughts, and comments. You will see on the screen already as we start that we're going to start today with our tricuspid regurgitation patients. There are two patients for you to consider. On the left, we have an 81-year-old female with a type 3B valve, so two posterior leaflet scallops. You can see that there is a broad jet of tricuspid regurgitation extending anteriorly to posteriorly with a curled septal leaflet tip. And you can certainly see that there's dense chordae in the subvalvular apparatus to think about. This patient has massive tricuspid regurgitation with tricuspid annular dilatation. And this is in contrast to patient 2 on the right-hand side of the screen, an 82-year-old male. Hopefully you will all agree there is clear leaflet tethering of a type 3A valve. There's septal leaflet impingement with the pacing lead traversing across. And the patient is in NYHA class 3 with post-capillary pulmonary hypertension and obviously with dual chamber pacing leads. So everyone's going to put your little devices to good use. With that in mind, can we have a quick show of hands for patient 1? Who would treat this patient with TEER?
Why not?
Hands up with your little devices for TEER. Some TEER. And then therefore, who would actually prefer to consider transcatheter tricuspid valve replacement in this patient? Okay, fairly evenly split. And then moving across to patient 2 on the right-hand side of the screen, can I ask who would be considering tricuspid TEER edge-to-edge repair in this patient? Okay. We're not seeing enough shiny lights for Professor Lertz and I. Who would actually think about tricuspid valve replacement here? So probably a little bit more for replacement for patient 2, and a little bit more for tricuspid TEER for patient 1. So with that, just to advertise and mention briefly that patient 2, given the complex central large coaptation gap that you see on the right-hand image on transesophageal echo, with the pacing leads, the septal leaflet impingement, the patient is actually going to be treated with transcatheter tricuspid valve replacement with EVOQUE, and we hope you will join us tomorrow at 12:20 in the main arena for the live case transmission. With regards to patient 1, I'm going to hand over straight to Jennifer von Stein, who's going to take us through the patient. Thank you.
Thank you so much. Can I have the clicker? Sorry. Thank you so much, honored colleagues. It's a pleasure for me to be here and to talk to you about the PASCAL Precision system. So we're going to focus this session on delivering targeted repair, and I'm going to do this together with my very dear friend and colleague Niklas Schofer, who's going to present the PASCAL Precision system to you here live with a beating heart simulator. And I'm going to discuss and present a case to you. So we just saw this patient, an 81-year-old female with exertional dyspnea according to NYHA functional class 3. As you can clearly see from her echo images, she has massive TR, enlarged annulus, and some very unfavorable anatomical characteristics, as you can see in the TEE. So ultimately, the heart team decision was that this patient was deemed at prohibitive surgical risk, and therefore we proceeded with a transcatheter edge-to-edge repair. So let's jump right into the procedure. You can see on the upper panel that we placed the first PASCAL ACE implant in the anteroseptal commissure. And after closing, you can clearly see that the gap is already a little bit smaller, but we thought that residual TR was still in the moderate range, so we decided to proceed with the second PASCAL ACE implant. And when we are in this kind of scenario, we are often left with this question, what strategy do we want to follow now? We have, in general, two main ways that we can go. We have the Clover strategy, where you would place at least one device in both the anteroseptal and the posteroseptal commissure. And then you also have the zipping strategy where you would place at least 2 devices in one single commissure. So the question for you would be here, how would you proceed? How would you treat this patient? I would ask you to raise your hand. Who would go, in this case particularly, for the clever strategy? Okay. And who would follow the zipping strategy?
You.
Okay, it's kind of like 80 to 20%, I would say. And with this, I would like to give it up to Niklas Schöfer, who is going to present how he would really proceed on this live simulator. Niklas?
Thank you, Jennifer. So maybe to make you familiar with this simulator, it's a total artificial heart based on a 3D print from a CT scan. It's hosted in a water tank and it's connected to this pulsatile pump. Then we brought a TE probe in it, so it pretty much simulates reality, not 100%, but pretty much. And then maybe if you can show the device here, I think most of you are familiar with the PASCAL device. So it consists of 3 independent catheters. We have the guide sheath here, which we can rotate and which we can flex. Then we have the so-called steerable catheter within this guide sheath, which can also be rotated towards the septum and towards lateral and also be flexed. And then we have the device catheter or the implant catheter, which we can use to navigate the implant then towards the leaflet. And we have here the unit where we can put down the clasp with the sliders and change the configuration, as you will see, of the device, and then in the end we have the release mechanism. We won't use this here. And now to the case. So we have exactly the same situation as you had, Jennifer, with your case. So we have one device already placed anterior septally. This is Roma. She will be the most important person here in the room because she's doing the echo. Maybe, Roma, you can show us where we have put the first device in a transgastric short axis. Is that possible? You can also see the boroscope on the lower left panel. And this is a little bit, so we're looking from ventricular, and you see towards 6 o'clock, there is the anterior septal commissure on the screen. So, and you see the first device is placed there already. And then we already steer the second device towards the posterior septal commissure. So this will be a clover attempt. And in echo, you might appreciate it. Roma is doing a MPR, and maybe, Roma, you can show the device arms. I will point a little bit towards the leaflets. Can you show us the device arm of the second device? With the pointer? Yeah, maybe in the upper right? There you can see the arms, and it's a short axis. And the first device, again, it's 6 o'clock. Exactly. So regarding the clocking, I think we're a little bit clocked. It's not 3-9 or 9-3. It's a little bit, let's say, more 4-10, maybe something like this. But to look at when you look at the boroscope, I think it would be a nice to orientation to grasp those leaflets. And when you want to cross the valve, we have 2 options. We can cross the valve closed, or we can cross with a closed device, or we can cross it by elongate the device, which is a distinct and nice feature of the PASCAL device. And I will do this by turning this knob, and now the device is elongated. You may also see this on echo, and I like to do it like this, and then we will carefully advance the device into the RV. And now we close the device and we go in capture ready position again, maybe a little bit deeper. And now you see we are capture ready again. So now we moved a little bit more to the center of the valve, so I move it a little bit more posterior. And we try to catch the lateral leaflet. I think now we are in a capture-ready configuration.
And Nicholas, you're being quite careful to avoid diving too deep into the right ventricle, aren't you? And particularly important in the case Jennifer's shown us in terms of avoiding caudal interaction.
Exactly. Yeah, and the more shimmer, I mean, now we're quite central, but you see also in this model we have a lot of cords here, and you can really nicely use this the elongation to navigate through those cords. Try not to advance it too deep into the ventricle. And once you have maybe entanglement or contact to a cord, you can lose this contact again by elongating.
Nicholas, what's your preferred strategy? Do you cross the valve elongated, closed, or open?
Yes, I cross the valve elongated. I like that. And then by going into capture-ready position again, I think most of the time you have less interaction with the cords by doing that. And especially if you want to put a second device in front of a first device, so next to it, I think you can really get very close to the first device by doing it this way. Okay, Roma, so do you think we have loaded the lateral leaflet, which is the posterior in this case, already? So we have that, yeah. And for the septal, I think we need a little bit different clocking maybe to come closer to the septal, and I try to move a little bit also to the septal. And I think now both leaflets are on. So when you grasp the leaflets, you have two different options. You can grasp them simultaneously, or you can grasp them separately. I like to do it separately because I think also for the imager it's nicer to concentrate first on the one leaflet and then on the other. If you want to grasp it separately, you have here this little knot which you just rotate towards yourself, and now you have independent control of both clasps. So should we go for the lateral, Roma? Okay. Okay, so maybe you can see, can you show us where we see the, so I think we nicely saw it in the echo, that the lateral is in. And for the septal, I think we still need to go a little bit deeper here.
And Nicholas, while you're moving to the septal leaflet, in clinical practice day to day, how much do you make use of MPRs and tricuspid tear versus conventional 2D mid and deep transgastric views?
So how much we use MPR? So routinely we use transgastric views for the clocking, and for grasping we routinely use the mid-esophageal grasping view RV inflow with X-plane, but you can do it differently, of course. I think many also use the transgastric view also for grasping. When the imaging is poor in the mid-esophageal portion, then what I like is short axis transgastric with MPR, so then you have all the information you need. Okay, Roma, I think septal is on, right? Okay, so we can grasp the septal. And then we can try to close the device. Here, I think it's important to release some tension, so I advance the device a little bit. Okay, so this will be the clover.
Independent grasping, how often do you use it?
I use it every time, not meaning that I'm using the so-called Tarzan maneuver, which you can use to really swing over to close large gaps. But I think it's nicer for the echo person to close one, and often I just move a little bit more septal, 1-2 millimeters, and then just for a gut feeling that I have really the maximum of septal leaflet inside. And then I close the septal clasp.
And what do you use more often, zipping or clover?
To be honest, zipping. Zipping is my preferred approach. So our goal usually is to close the anterior septal commissure completely, because we think that we have the best annuloplasty effect by doing so.
That's an operator preference. Let's
Yeah,
hear a little bit what the evidence might say. Can we go back to Jennifer?
That's
Okay.
good.
Yeah.
Should we go back? Okay.
Okay.
So thank you for this excellent simulation. So this is exactly the point. This is often the question. The decision between Clover and zipping is clinically a very relevant question, and that's why we investigated the acute impact of edge-to-edge repair on tricuspid annular dimensions, and especially the effect of these two strategies, and its association also with residual TR and clinical outcomes. And we investigated this in a small cohort of 103 patients. Median age was 81 years, mostly women, and in a very advanced symptomatic status. And as you can see, with a broad range of severe TR, with almost 30% and massive and torrential TR. So what we actually could really see was that edge-to-edge repair really induced indirect annuloplasty, and this was also not only in the linear dimensions like AP and SL diameter, but also in the more sophisticated dimensions like the tricuspid annular area and the tricuspid annular perimeter. And this reduction was actually associated and correlated with a reduction or with an improvement in tricuspid regurgitation. And what was even more interesting was that the Clover strategy emerged as an independent predictor of greater tricuspid annular area reduction as compared to the zipping strategy. And when we stratified these patients according to achieving a very good annuloplasty effect and also a very good procedural result, we could see that actually the ones that had both had the best outcomes, not only with regard to survival at 2 years, but also in terms of symptomatic improvement. And very recently, we also investigated the impact of different T-tier devices on this annuloplasty effect, because our hypothesis was that actually these two devices might have distinct design, might have a distinct influence on the annuloplasty, since they also have distinct design features. But as you can see, there was very similar groups, but the only thing that was a little bit different was that independent leaflet capture was more frequently used in the PASCAL group as compared to the TriClip group. But the result was that actually annuloplasty was achieved in both groups, and there was no difference in between these groups. So let's go back to our case that we had in the beginning. So as you can see on the upper level that we placed a second PASCAL ACE implant in the posterior commissure between the P1 segment and the septal leaflet, but there was still some residual mild TR left. So we thought that we could optimize this a little bit, and we optimized leaflet insertion and also the device orientation. We had on the lower right level, you can see that we now have a little bit a 9 and 3 p.m. orientation. And then ultimately we were pretty happy with our final result, coming down from massive TR to trace TR. And if you look at the discharge TTE, you might also see that there's already a significant annuloplasty effect when you compare it to the baseline TTE. But you can also quantify this with 3D MPR. If you have really good TTE images, this is also feasible in TTE. And as you can see, we had a reduction in tricuspid annular area of approximately 7%. And for this specific patient, we also have an illustration showing that how the Clover strategy really induces valve reshaping. So to summarize this, we can really say that edge-to-edge repair has an indirect annuloplasty effect, and this was the same for the TriClip and for the PASCAL ACE system, and even more pronounced when using the Clover strategy as compared to the zipping strategy. We think that also independent leaflet capture might be very advantageous, especially because of bridging larger coaptation gaps and also in optimizing device position, which is particularly important in the tricuspid valve where you have more than 3 leaflets very frequently. So with that, we'd like to thank you so much for your attention, and if you have any questions, thank you so much.
Thanks very much, Jennifer. So some really interesting data that we've seen now about a Clover versus a zipping strategy. Given what Jennifer's shown us, I suppose it opens up questions for us, Philip, doesn't it? How much is annuloplasty important over and above or in addition to TR reduction that we have conventionally focused on? Just a very quick show of hands with what Jennifer's shown us. Who tends to go up front with a zipping strategy if the anatomy is suitable? And therefore, who then goes for a clover strategy up front on the basis of anatomy when it's available? Probably a fairly even split at the moment. Philip, any thoughts, comments?
Well, I'm a strong advocate of sipping. I believe this is, in most cases, an easier approach, but then it's not about our feelings, it's about evidence. It's a great study. It's very important. I wonder what the thoughts are, whether anybody who preferred sipping before would now consider clover to be performed more often. Yeah, there we have a comment to make. Please.
Okay, so it's Bushra, hello. It's just a question, actually, because trying to understand this concept. So I believe in zipping, although I'm now rethinking this strategy. And as I understand it, the way the annulus is, the reason why we like the anteroceptor commissure is because it's part of the fibroskeleton and we pull everything in. But of course, the annulus dilates in this septolateral direction, so the posterior lateral wall goes out. So it makes sense if you were to anchor sort of halfway along that valve and pull that inwards, it makes sense. So to me, it depends on the valve anatomy. So what the morphology is like. So if you've got a really big, long anterior leaflet and a smaller posterior, zipping is perfect, and I'm going to really get a good annuloplasty effect. But if I've got a P1, P2 valve with a very short anterior leaflet, then it makes sense to drift more centrally and further up. But then the question comes about the technique, the clocking, and the risk of clefts opening up and causing more leak and causing a hole in the middle. That's why I worry about the clover technique.
Thanks, Bushra. I think we've got another comment on this side from Paddy.
Thanks, Ealing. Well, Bushra, super answer. That was absolutely tour de force. Thank you very much. I mean, I think zipping is easier, Philip. It is easier, and you start with it. If you've got a long commissure, then that's what you do. But I do think I might be more inclined to think a bit more about clover, having seen that evidence. I mean, it actually makes sense, doesn't it? You know, that you would get a better reduction in the annulus with a clover technique. But I think, you know, what happens if you put your first clip on the anteroceptal, then you do posteroceptal, then you leave a gap? It's quite tough to get back in between. So I'd take care of the anteroceptal first of all, but I maybe have a lower threshold to look at the posteroceptal.
Thank you for that comment.
Jennifer, another question. For your analysis, if you put the second device on a different leaflet, whether it's P1 or A2, so the posterior anterior leaflet, but you have the same clocking than the first, is this clover or is it zipping?
I think it's still zipping, even though I get the thought. But I think it really matters. The first comment was really great. How much leaflet you actually grasp, because this is the theory behind it. As much like if you can get as much leaflet as possible, you really have the pulling force on the annulus. And also it matters if you have a really small P1 segment. And I think these thoughts really should influence our procedure. And I think that, as I come back to the question, I think that would still be the zipping.
Yeah. I think that's the key. We call it TEER. It's a leaflet device, but actually we do indirect annuloplasty. And you have to position the devices and do the clocking in the way that the annuloplasty effect is as large and as robust as possible. And whether this is by sipping or clover then probably depends on individual patient anatomy. Okay.
And given it's all about optimizing outcomes, given the packed agenda, I'm going to hand over to Philip to move on to mitral regurgitation.
Yes, so we switch gears a little bit, and now we move to the mitral valve. We will start that part again with 2 patients. Can we have that on screen, please? And please look at these patients carefully. I will ask you in a second how you would treat. And again, we do have the option of repair, but we also have the option of replacement. On the left, this is an 80-year-old woman. She has degenerative MR, a P3 prolapse, obviously MR grade 4. She's clearly symptomatic. And if you look very closely, there's also something which here is named pseudocleft. Then on the right, the patient, 70-year-old male, posterior leaflet restriction, caudal rupture in A1 segment, also very symptomatic, MYHA class 3. We see annular plus subvalvular sclerosis and obviously annular dilatation. We start again with the patient on the left, and I would like to ask you to use the little thingies and maybe put also the light on, and we can see it a little better, and raise it when you think that the patient on the left should be preferably treated with repair. All right, then please raise the light stick when you think that replacement is the right thing for the patient on the left. I think this is a win for repair. We can agree on that. And then on the right, who prefers repair? Who repairs replacement? Okay, pretty obvious outcome. So preferred choice of treatment for the patient on the left is repair, patient on the right is replacement. We will continue to discuss it obviously during that session very soon, but before that we will hear a little bit more about data and evidence. Please.
So we'll go with the first case. It was an 89-year-old lady that was pretty okay. She was known because of a prior atrial fibrillation, and she already was known also of having a mitral P3 prolapse. The thing is that she was stable, but due to oral anticoagulation, she had a GI bleeding issue. And for this reason, she got admitted in the emergency room and brought to the cardiology ward. So the thing is that we discussed the patient on the heart team. She was considered a high-risk patient for surgery. But on the other hand, the geriatrician evaluated her. She considered that the patient was what we call a elderly, so she was otherwise in a good shape. So there was no futility on trying to treat this patient with TEER. The thing is that when we evaluate the anatomy, there are several issues that we are concerned about, because if you check the jets in the intercommissural view, there is a really eccentric jet that is due to the P3 prolapse, but at the same time there is another jet that comes from the middle. So the valve is completely distorted. And if we go to the 3D images, you can see the prolapse close to the commissure. There is a really short P2 leaflet, and there is this sort of what we describe pseudocleft, that the color is not coming from there, but we are concerned that if we pull her there, we will have a bad result for that. So in the summary, it's a really ugly valve that we want to be really, we have to have a really safe pathway with no surprises on the road. So that's why the reason of how important is predictability in those cases. Don't you think, Jonathan?
Yeah, so I think this is the kind of case where I'm getting myself mentally prepared for maybe a fairly long procedure.
That's right.
And I think what we really want to do with first clip is make sure we get a good reduction and a good result. And especially the further you go into the commissures, I think it starts to get a little bit more unpredictable what's going to finally happen. And I think we've all probably had cases where you place a clip and you release it and you actually end up with a result that's different to what you were previously expecting. So ideally, we're going to be having exactly the same result after we release the clip. And this is something that's been looked at recently in the Edwards post-marketing registry. This is a sub-study from the MyClass registry, and looking at what happens to the MR grade after the device is actually released. And what this has shown in about 100 patients is you get, in general, a very predictable result. So you make the clasp, you get the reduction. After you release it, you're not seeing a big difference in the vast majority of patients. So I think it's very critical in a case like this to be doing that.
Indeed, I have to say that in this case, our main concern was getting the whole prolapse with the first PASCAL and not having a residual jet towards medial. So we're concerned that if you release the device and after that you have a medial residual jet, it was going to be difficult to fix because you are almost already on the commissure. So in this, you can see we have almost the whole clasping of the leaflets. We close the device. You can see the tension on the device. And this is the result with the device. This is the result that we have with the device still holding.
About the fact that the device is opening and closing throughout the cardiac cycle, is there anything you look for, and what does it mean?
So in our cases, it's the same that we do with the clasps. When you see that both clasps they are moving heavily, that means that there is a lot of tissue inside. In this case, I have to say I'm showing just this imaging, but I won't lie. I mean, we did like 10, 11 attempts because we really want to be completely coaxial to the prolapse and having the hole inside, so we stop the movement of that. But all the movement is inside the device. So that's what we can see there, the opening and closing, because there is a lot of tissue inside. But despite that, you see all the medial jet is going out, and now we have a more lateral jet that is really well organized, and it looks that it's pretty good to fix. Indeed, if you check where we release, the result it's even better. So that was observed in the 13% of the cases. So we have some doubts if we need to fix that, but we thought that the jet was pretty broad and we could do the better job. So that's why we went with the second device. And with the second device, it happened the same. You can see on the left of your screen, the device is held, and in the right, the device has been released, and the MR is exactly the same. So this was really, really predictable. Moreover, you can see that the appendage was closed during the same procedure because she had bleeding issues. And the thing is, due to that, we're lucky that we had a prior CT of the patient and a follow-up CT of that. And you can see, if we compare them, the anterior-posterior diameter of the annulus has a clear reduction, almost 11% of the reduction. So it really exists a clear effect of annuloplasty effect when we do these cases. So Jonathan, can you comment about that?
Yeah, so I think this, for me, was quite interesting because we know that the annulus dimension reduction in tricuspid is the key to getting the good results. I wasn't quite so aware that that's actually an important factor in the mitral side as well. So just to show anybody who's not familiar with the various dimensions of the mitral valve, the one where we just demonstrated here in this case very nicely is the AP diameter between the A2 and P2 dimensions of the valve, of the mitral valve. We also have the lateral and medial distance, and we can also measure the perimeter all the way around the annulus and also the area as well. So if we actually then go on and have a look at what happens after using the PASCAL device for a mitral implant, then this is a recent study that actually shows all of these different measurements reduce in the immediate pre and post clipping measurements in echo. So we see significant reductions in the AP diameter, also in the medial lateral, the area and the perimeter as well. And actually the factor that correlated most with the reduction in MR was this reduction in the AP diameter. So I don't know if that was something that was ever intended by the Alfieri stitch when it was first done. Maybe a surgeon can enlighten me on that. But I think we see very nicely, and what I like from your case here is we see that actually one of your clips is almost in the middle.
That's right.
Although the pathology is quite far to the side, and in my experience, we often plan, okay, we're going to aim directly for the pathology here, or where the jet's the worst. But frequently we end up going right in the middle, A2, P2, maybe because we're influencing this AP diameter to get the result.
I totally agree. I mean, in the case, we started from the commissural part because it was, the part that was more sick, and we tried to fix it first, but we knew from the beginning that we need to finish with A2, P2. The good thing is that we had a good follow-up of this patient. This is a patient that was done 5 years ago. So probably this annuloplasty effect helps also in the durability, because we can see that the result is almost the same that we got at the end of the procedure and 5 years later. Indeed, the patient didn't get any admission on the road, so this is the best news for her.
Yeah, so I think it's a fantastic result 5 years later as well for this patient. We are still looking for really solid data as to what happens down the line with edge-to-edge repair. We have some registry data here presented with PASCAL. On the left side, we can see the initial MR severity, obviously 3+ or 4+ in all patients, with a very good reduction in the initial phase, up to 30 days. And these patients are dying. So 50% of them are dead by 5 years. We know this is not a big surprise. These are very sick patients, unfortunately. But reassuringly from the data that we have available, patients that had follow-up with an echo core lab, in this case, we're not seeing that a large number of patients are coming back with new MR. So obviously some of the ones with the worst MR are probably not surviving as well. Maybe goes hand in hand with the pathology. But I think we can be reassured that when we get a good result initially, there's a very, very good chance it's going to hold for multiple years or longer.
I can't agree more. I mean, in this case, we have shown that we were precise because we wanted to go to P3. You saw the leaflets. I mean, the subvalvular apparatus was super hostile. They had a really weird shape, and we could go in and out really safely. We just could have a good capture. We had an AP diameter reduction and durability. That is at the end what they're looking for. She was in 89. Now she's not 94, and maybe she gets to 100. So that's we're expecting for her. So I think it is nice. It shows nicely all the benefits that we can get with this device.
So I'll see you here at PCR 2031, right? We'll
Hope
present it
so. We
again.
can show the case again. Thank you.
Thank you.
So I found some surgeons hiding in the back. They're suffering because they hear that it took us 40 years to recognize the annuloplasty effect. 40 years after surgery, obviously understood that much better. One of the criticism about TIA always was that, yeah, we treat the leaflets, but we don't support the annulus. Mm-hmm. Now we can prove that we do have an annuloplasty effect. Is this strong enough?
I think I have to say yes. So I come from a site similar to Niklas Schofer, which has a long-standing history of TIR procedures. Some of you may remember Olaf Franzen, who in fact did the first M-TIR in Europe back in 2007, I think, Niklas?
Yeah, something like that.
Something like that. And as a matter of fact, the effect of annuloplasty, or the annuloplasty-like effect of M-TIR, we just discussed with Thilo Noack from Leipzig, who also says he tried to publish this. When was this?
10 years ago.
10 years ago, but was rejected. But
he sent it to a surgical journal.
No, he didn't. No, he didn't. So as a matter of fact, I think it's undeniable that there is an effect now with the M-TIR procedures, and it actually is intuitive because it's very different from surgical edge-to-edge, not only by indication, because we still do edge-to-edge in surgery, but not for these types of procedures, not for secondary MR, but for Barlow's disease, things like that, where there's a lot of leaflet tissue where there will never be a transition of force onto the annulus because there's so much tissue, right? But I think in general, in summary, yes, I believe in the annuloplasty effect.
That's a strong statement. Thank you.
Any additional thoughts and comments before we move on to the next section? And if not, I think we're then going to see some data about transcatheter mitral valve replacement.
Good morning. So the other patients that you've seen before, patient number 4, is actually going to be shown in a second, and it looks like a good candidate for transcatheter mitral valve replacement. What devices do we have now? We have the SAPIEN M3 system, which is the first and for the moment only approved transfemoral transeptal system to do a transcatheter mitral valve replacement. The procedure is done in 2 steps. The first step is deploying a dock around the subvalvular apparatus, which acts as an anchoring system for a balloon expandable valve, which gets implanted in the second part of the procedure. The dock that you see depicted over there is made of 3 functional turns and 1 encircling turn, which is a little bit larger and is used to go around the subvalvular apparatus and the leaflets. There is then a PVL guard system, which minimizes the risk of having a leak in the medial commissure, and some radiopac markers which help with deployment of the system. The valve is a classical SAPIEN balloon expandable valve. It's a bovine pericardium with a PET skirt, which is used to respect the native anatomy and to avoid any damage to the leaflet when it gets implanted. The device has been studied in the ENCIRCLE trial, which enrolled symptomatic patients with severe mitral regurgitation. There is a main cohort of 300 patients, a MAC registry of 100 patients, and a failed TIR registry of another 100 patients. For the moment, we have data on the main cohort, and the primary endpoint of the study was a composite endpoint of mortality and heart failure hospitalization at 1 year. When we look at these patients, we see that the average age is 77 years old. The predicted STS score for mortality for mitral valve replacement is 6.6%, which is quite high. They had congestive heart failure in 75% of the cases. When we look at the study flow, we see that at 1 year we have 243 patients which are alive and in the study. The results are shown here. The procedure time is slightly above 2 hours, and the most important procedural time is dedicated to the dock deployment, which took an average of 65 minutes in the study. The valve deployment time is quite quick, only 12 minutes in the study. 96% of patients were discharged home without going to a rehab facility, and the median hospital stay was just 2 days. The safety results are very good, with an all-cause mortality which is below 1% at 30 days and a stroke rate below 3% at 30 days. When we look at the 1-year data, we see that the cardiovascular mortality is 8.9% and the disabling stroke rate is 3.9%. This is the primary endpoint of the study, which has been met in 25.2% of patients. That's the rate of death and heart failure hospitalization. It was below the intended performance goal of 45%. Looking at the secondary endpoints, we see that at 1 year, the MR severity is very good, with 96% of patients having at most mild residual regurgitation and close to 80% of patients having none or trace. The results in terms of NYHA class are good. 88% of patients in class 1 or 2 at 1 year, and also the improvement in quality of life as assessed by the KCCQ score is good, with an average increase of 18 points as compared to baseline. So the ENCIRCLE trial is the first trial of a fully percutaneous TMVR to achieve both its primary and secondary endpoint. The 1-year composite rate of death and heart failure hospitalization is below the performance goal. The observed 30-day mortality rate is low because it's 1/10 of the surgical predicted mortality, and also the results in terms of residual MR severity and improvement in quality of life are good. If you want to see the full study, you can look at the Lancet where it has been published. Thank you. Now I think we will see the actual outcome of the case, and I will give the stage to Björn.
So while Björn is preparing, I would like to ask a couple of questions to you. First, please raise your hand. Who has heard about M3 before? Okay. Who has seen a case? And who has performed a case? Okay, so I think that should be useful now, what we see in a second. Please.
Yes, thank you for the kind introduction and for the opportunity to present our case of a SAPIEN M3 implantation to you, ladies and gentlemen. As this is a live in the box case, we have decided to divide the video presentation in 2 parts. And in between, my dear colleague, Dr. DiMarco, will show you on the simulator how the encircling of the subvalvular mitral apparatus is done, which is a crucial part of this 2-step procedure. But first of all, I would like to start with the clinical characteristics of the patient. This is a 72-year-old patient, which is quite symptomatic in New York class 3 and has been hospitalized due to left heart failure twice in the last 12 months.
Our first time.
Believe it or not, our dear heart surgery colleagues had the hands on this patient 4 times. They started with the surgical repair of aortic coarctation in 1982, and the last operation was on a replacement of the part of the aorta with a valve-bearing conduit in 2022. So with an SDS score of about 5%, there was not much discussion in our heart team who should take care of this mitral valve anyway. Instead, we are, of course, interested in lively discussion on your part, which type of intervention repair with edge-to-edge or replacement you would advocate for this mitral valve. To help you to make up your mind, I will try to give you an echocardic insight in the pathoanatomy of this mitral valve. Overall, we see a central jet and a more lateral jet, which is a little bit more eccentric. We have quite an enlargement of the mitral annulus, mainly due to left atrial enlargement. We have quite some tenting, with a tenting depth of around 12 millimeters. The overall opening of the mitral valve is sufficient, with 4.3 square centimeters. And we have some shorter rupture at the A1 segment, but without flailing segment. When we look at the screening CT, which is mandatory for planning this procedure, we see again a dilation of the mitral ring of around 45 millimeters from commissure to commissure. The calculated neo-LVOT is quite large, so there's not much risk for an LVOT obstruction after valve implantation, and we'd only see a slight sclerosis of the mitral annulus. So we start with the first part of the procedure, the video presentation. I hope the images are moving or the video is starting. Okay. As all transseptal puncture, we have to start with a transseptal puncture to get, of course, to the mitral valve. The screening CT has suggested an optimal puncture height of around 30 to 35 millimeters to have enough space in the left atrium to deploy the dog steering catheter. There's Dr. Lauten on the left and Dr. Salomon from our center who perform the intervention. I'm the echo guy, so I'm not seen. The echo images have to speak for themselves. The next step is to place a pictal catheter into the left ventricle and to perform an angiography to mark the plane of the mitral annulus. And this is then marked on the angio monitor to give some orientation for the dog placement. After that, the dog steering catheter is inserted, and the echo builds here a 3D en face view on the mitral valve with the crosshairs pointing at the mitral commissure, which is the entry point for the dog tip. So it takes some maneuvering. And now we have this C shape of the dog steering catheter now hovering above the mitral commissure. And by deflexing, then the tip will drop through the middle commissure. And I try to see it on the echo. Now it's nearly through. Now I turn the 3D image to look at the leaflets if there's any impingement, which we would like to avoid. And this is the first checkpoint of the procedure. And now I would like to hand over to Dr. DiMarco, and I try to support him with the echo as good as I can.
I need your help because echo is really a critical step of the procedure. The simulator has been already shown by Dr. Schoffer before. This is obviously a mitral valve anatomy. What you see on the borescope, which is maybe more easily identifiable, is the mitral valve as seen from the left ventricle. So you basically see on the left, bottom left of the screen, the medial portion. On the top left of the screen is the LVOT and the aorta. And then you have the lateral commissure, where you see the tip of our encircling turn.
So we have already passed the LVOT.
We have already passed the LVOT. That's another important step, which probably we will see maybe later on the image. Once you get into the medial commissure, you need to advance the dock and pass the LVOT after checking for these parallel maneuvers, making sure that the circles are parallel to the mitral annulus. I will show you really quickly the system. We have a sheath which goes across the septum, which is held throughout the procedure from the beginning to the end of the actual valve deployment. And there are two different delivery systems which are inserted in the sheath. The first one, which is used to deploy the dock, which has some controls, one distal and one proximal flexion controls, which are needed to maneuver in the atrium and to go below the medial commissure. And then there is this portion over here, which is used to advance the dock and to actually release the dock and release the PVL guard. Basically, once we are in the LV and below the mitral valve annulus, we release the dock by advancing this catheter over here, which goes around the subvalvular apparatus. And once you do the first turn, which is probably the most critically important portion of the procedure, you have to stop and you really have to have a meticulous echo check of the job you have done. You want to be 100% sure to have fully encircled the subvalvular apparatus. So this is where I stop and where the echo really comes in and checks for the job you have done.
Yes, echo has already established an intercommissural view on the left side, and I try now to go through the valve from the lateral side, from the P1 segment with the X-plane, and try to delineate the first turn, which is seen here. And you can appreciate the chordae, which are a little bit behind. And you see the tip of the leaflet above the dock. We have some shadowing that's sometimes very difficult from the catheter, from the dock steering catheter. So you have sometimes switched to a transgastric view to get a better view from the chordae. And then you move to the P2 and P3 area. And again, you can see the dock, or the first turn of the dock, behind the leaflets and behind the chordae. So I'm quite happy.
You're happy with the position. So basically, all the three areas,
Philip is not happy.
Philip, how easy is it on echo to reassure that all the cords are inside?
It is tough. It's the longest period of the procedure. It depends. You need several images from mid-esophageal, deep esophageal, transgastric to be 100% that every part from P1 to P3 is captured.
Yeah. But what you will see in a second is that once you've made it with the first turn, it gets easier and easier with the second and third turn because the anatomy came already in. Is there anybody who has a question, would like to make a comment?
I see in the image on my right side, the ring, one of the leaflets seems to be in between those two wires. How do you control that?
In between the wires? You mean this image?
Yeah.
This is the dock steering catheter, and this is a dock circle.
Yeah. So it seems to be between.
In the echo or in the bars?
You mean the cords on the lower left?
Yeah, the BVL.
Yes, this is spot on, absolutely, but this is due to the model. Ideally, the ring has to go around all the cords, but this is also due to this is only due to the model, so we had to compromise a little bit. But this is absolutely correct. Yeah. In a patient, you have to make sure that all the cords are inside of the ring and none are outside.
Agreed.
Any other questions from anyone? I suppose this is the crux of the procedure that we're seeing that will set up for the success and the speed for the rest of the procedure. So it's a good opportunity to ask any burning questions. Yep, we've got one here.
Well, what happens if you miss a couple of cords?
We have to go back and send out again.
Yeah, and you haven't noticed, and you implant the valve.
So you actually have to, let's pretend that we missed somehow the medial cord. So what I would do is to go back, okay, and pull out the whole system to kind of pull it more medially, and then resend out our encircling turn in order to get the cords. And that's where I would stop again and ask again for another verification if the cords are now within the catheter or not.
And I think to that question, I mean, given the number of pairs of eyes in the room, it would be very unusual for us to proceed to valve deployment without someone having watched that. It is meticulous to the nth degree.
Yeah.
We have one question first, please.
We have
Thank you. I have. Thank you for the talk. The 3D image on the ventricular side, it is important in this evaluation.
Sorry,
what's that?
Didn't get a 3D image.
Yeah, the 3D image.
At this point of the procedure, how good it is to help to delineate the dog, and if it's the dog is behind the chordae. It is tricky, I would say. I would prefer 2D and explain and transgastric views to really see the chordae. Because in 3D the chordae are quite thick and it's not always good.
Let's see how it would look on 3D.
Yeah.
Let's just, I mean, we can play with the echo now.
The patient is stable.
The patient is very stable.
Yeah, absolutely.
You see, I think it's very difficult to assess the subvalvular apparatus, and especially the little chords, the little chordae with 3D.
Yeah.
So sticking to 2D seems to be the take-home message. I think we've got another question on this side of the room.
Yeah. Compared to tendine, does the dock that encircling the chordae on the anterior leaflet prevent the LVOT obstruction better than tendine, or not?
I'm not aware. I don't think there is any direct comparison between the two devices. And still, after this step, you have to implant a balloon expandable valve. There are some criteria to minimize the risk of LVOT obstruction. But I think at this stage, it's very difficult to compare two devices which have no direct comparison.
In regard to our small experience, these patients we sent to tendine or to SAPIEN M3, vice versa, they both dropped out for LVOT obstruction anyway. So,
and I think Nicholas has something just to add to that particular point.
And just a question: is there any impact of the dock on the severity of MR? Do you experience that? Is the MR going down with the dock alone?
No.
Tiny bit, but not maybe. Not
one patient with a combination of mitral regurg and rheumatic disease. So when the dock was implanted, their grading really got up, and we had really to hurry up. But we didn't see a reduction of MR.
Anyway, it's an important question or comment because obviously the dock is there to allow subsequent valve implantation, but what it also does, it brings in the anatomy, which sometimes is referred to as papillary muscle approximation.
Yeah.
We don't know what it means exactly, but we would think that it helps with remodeling, and it's just a different concept. So the dock is there to allow subsequent valve implantation, but it also provides some papillary muscle approximation, which conceptually is important, and we will see in the future what it means.
Last question.
Just in line of this last comment, I was wondering if there are any indirect signs of having all the chordae inside the dock, in terms, for example, if you're dealing with a secondary mitral regurgitation, you expect some reduction of the MR, not if it's a prolapse, for example, or if there is a reduction in the mitral area or the mitral annulus dimensions when you've got everything in?
I haven't measured.
I think you need to really check on echo that you have the chords in 2D, and relying on indirect evidence at this stage is probably a little bit too risky. You want to actually be sure, 100% sure that your chords are fully encircled.
Cool. Thank you.
We probably continue. No?
Yeah.
Yeah, I think
the second part of the video.
Yeah, but don't you want to deploy the other turns in the dock?
Okay.
Complete the turning.
The job is not done yet.
This is just to show you that after you have observed the first turn, the second and third turn go really quickly. And you can easily advance them like this. And do a final echo check once all the three circles have been deployed.
Yeah, now so you can see these dots stacking above. So these are the three turns. Each of the dots is one of the turns. So it's relatively straightforward.
Exactly. And now we would take away the sleeve and deploy the PVL.
Yep.
Let's see the end of the case, Pierre.
Yes. So I need the second part of the video, please. And here we go. Now, we start with the DOC catheter now positioned below the mitral valve, near the medial commissure and pointing towards the LVOT. And we now send out the first quarter turn of the circle. And the echo now, or should switch to an LVOT long axis view with an X-plane and checking the LVOT and especially the aortic valves, that the tip of the DOC is not impinging the cusp of the aortic valve. We also use color Doppler to see if there's any new jet as an indirect sign. And when the tip of the DOC has passed the LVOT and is moving towards the lateral commissure, we then switch with the echo to an intercommissural view as seen on the simulator. The colleagues are quite fast, still struggling to establish a good intercommissural view. Here's now the intercommissural view. And now moving the X-plane from lateral to medial to check if we have captured the chords and if the leaflets are above. And in reality, it took us several attempts with power maneuver of the DOC steering catheter to get really behind the chords. And if this is done, the first turn, the second and the third turn is quite straightforward. Oh, you can appreciate here now the DOC catheter. We also use transcatheter view. Sometimes very good to see here now the DOC, the first and the second turn is stacking up, and then the third turn. Now all three turns are deployed. We are now moving to an LAO view in the angle to see the sleeve marker and the full deployed DOC. We retract the sleeve. Oh, my dear colleagues do it. And then the marker band alignment and the full exposure of the DOC is the next checkpoint. It takes quite a while now to retract the steerable catheter. And now the so-called parallel leak guard is deployed or brought forward towards the mitral commissure. You see here a cushion-like structure which should prevent parallel leakage. And when everything is in place, colleagues give now this little wheel slack towards the sutures which are attached to the atrial turn of the DOC. So the DOC is now relatively relaxed in its position, but still attached via the sutures. And the echo has now the job to measure the distance between the first circle towards the annulus, so that the DOC is not too deep. That's the next checkpoint of the procedure. And then the sutures are cut. So now we're going to the next step of the procedure, and we bring in a pigtail catheter, and the echo has to check that's really inside the DOC and that there's no interaction with the atrial turn, for example. Via the pigtail, we put in the short tip safari wire, now placed in the apex of the left ventricle. And the commander is brought in with the loaded SAPIEN M3 valve, and again the echo has to check that there's no interaction with the atrial turn or the DOC itself. Let's glide in smoothly. Now it's in position, right in the middle of the DOC.
What's the landing zone? Where do you want to end up with?
In the middle, slightly maybe above, I would say. I'm not doing it. So this is implantation. You can see that the spirals are moving and the PVL guard is moving. And you see still can appreciate a waste here in the valve. So a second inflation is mandatory to fully deploy the valve during, of course, rapid pacing. And it took quite a while. So these are the final echo images. The mean gradient is around 3 millimeter mercury. So the result is accepted, no relevant peripheral leakage, a mild central jet, and then the guide is retracted. Of course, there's still an ASD after this 29 French guide, but it is accepted. And last but not least, we have to close the puncture site with a closure device.
So that means that initially you wouldn't close off the ASDs?
No.
Okay.
No, in most cases it's under 10 millimeters, and we check for hemodynamically relevance, but we didn't close it yet. In the 8 cases we did. Yeah, these are the echoes. I got a little bit excited at the end, so showed several images, typical imager. Thank you so much.
Good. So
Any question?
Who has questions? Who would like to make a comment? Until you decide whether you want to say anything, maybe you make a few comments about post-procedural management of these patients.
Yeah, we, in regard to anticoagulation, we kept our patients, nearly all have atrial fibrillation. We kept them on DOAC. We don't use warfarin. And of course, we need an echo at discharge, and we see all patients after 1 and 3 months at least. Also with included in CT scan to check for any thrombus.
Good. Conduction disturbance?
Not seen yet.
Good.
Any other questions from anyone? It's a lovely, elegant demonstration of the system, which it does seem to translate one-to-one in practice.
Yeah.
Yeah, sorry.
Thank you. As an imager, I think that the critical point is just the imaging quality to assess the subvalvular apparatus. I mean, in your case, the case that you show was everything okay, nice to sweep the commissure thanks to simultaneous biplane from the commissure in medial and lateral, and you switch in transgastric. But I guess for me, sometimes I have an artifact of a calcium spot of the leaflet or the calcification of the annulus, and you can have some shadowing. So I think that the critical point is the imaging to be sure that and assess that you are capturing all the apparatus. So this is not a comment. It's not a question.
It's a very appropriate comment, Gemma. I mean, the imaging is really the critical step. We've seen that you need to see the tiny cords. So obviously, when you have calcification, the level of complexity increases. MAC patients, we will see the results in the MAC cord, but that's a much more complex subset to treat, for sure.
Yeah.
Thank you.
I agree. Yeah.
It's, as in most of these procedures, I mean, also for complex tricuspid, you need a good imaging. So, yeah.
The interdependence can't be underemphasized. I think we've got another question on this side.
Well, actually, I'm waiting for the release of the prosthesis in vitro. Why not?
Next time, yeah, next time.
That's for the next year's session. Any other thoughts, comments?
So, do you have any thought or any? Are you worried about the aortic? I think this patient had an aortic valve placed as well. So, any worry about interaction between the two valves?
Yes, of course. Yeah, we have really to be careful to check the LVOT and aortic region when the dock tip is passing through, and this can take some time and parallel maneuver of the dock steering catheter to not get any interaction with the cusp. Yeah, it can be difficult.
Yeah.
Philip's a better thrower than I am, I suspect, Martha.
Thank you. So regarding imaging, as said before, you have more experience probably in the room, some tips and tricks how to get good images, maybe playing a little bit with the focus, harmonics to see better the chorda? And also, second question, what's the average time for implantation of the valve?
Average time about an hour, I would say, and most time is these encircling maneuvers of the first term. Yeah, you can't do pretty much. We need to have a good TE probe with a good quality, to be honest. I prefer explain because I think the borders of the leaflets and so are more sharp to see and to delineate. Focus optimization, trying different position in the esophagus, a little bit up or down to get away from the shadows from the guide catheter above. But yeah, you can't translate from the screening the image quality on the table, to be honest. Yeah, it's not 100% plannable.
And I think the average time in the trial for dock implantation was 65 minutes. So it matches with exactly with what you said because of these parallel maneuvers and yeah, that's it.
And regarding the transeptal puncture, is it the same like for the mitral valve repair?
Lower.
I'm asking because is there any possibility, imagine that you have the full study done? Because in this case, personally, and taking into account the complexity and the risk-benefit, my first approach maybe is let's try with a PASCAL device, and if it's not working, we switch and we go for the entry directly. So that's why I'm asking if the transeptal is the same spot, everything, maybe it's convenient having the whole study done, so you are ready to do one. I don't like it, I go for the other.
Anyone experience of attempting a repair and if failing, implanting immediately in the same procedure an M3?
Only one in the room, I would say.
Federico, but is the transeptal the same spot?
Transeptal
is it was 30-35 in this case, so it's come from the CT planning. It might be a little bit lower.
Okay.
I think what we have really seen is potentially another solution from a transcatheter perspective for our patients, and actually really carefully selecting the patients that might most appropriately benefit from this platform, from the elegant demonstration we've seen. We've got one more question.
Have you ever got worsening of MR due to caudal tethering or else rupture, for that matter?
Could you say that again, please?
Because of the caudal impingement or tethering or rupture, you have got worsening of MR after the dock delivery.
Not worsening FMR after the dock release. No, in my few cases for the moment, I haven't observed that yet.
Was there any?
And it's always, I mean, if you release the dock appropriately, then you implant the valve.
And there were any shorter ruptures or during the trial, or does that happen? We haven't seen. Luckily not.
Created, any clinical relevant issue.
Okay. Maybe one issue I can just ask about for people with more experience than me. Sorry, behind you.
Oh, sorry.
Sorry. Sometimes you can end up with a little bit of very mild or trace MR in the commissures after SAPIEN M3, and we had a case where this actually produced a relevant hemolysis, and it was actually very difficult to treat with plugs afterwards. I don't know if you have any comments about that, or maybe the best way to deal with it.
We have only 8 cases done yet, and one has now only a mild power leakage, but it produces hemolysis. So we have to bring her back in and try to occlude it, but we are not 100% sure how to do it.
I think in the circle tie, there was a 5 to 7% rate of clinically relevant hemolysis. So that's
they attempted
something
occlusion, no? They attempted occlusion in this case.
In some cases,
yeah.
I suppose so.
And they were successful around 70%, I think. And
I've heard of successful occlusion, but I have one example of where it was not easy, and in fact the MR was made worse by attempting to close it. So,
and did that solve the hemolysis or not? Worsening the MR, maybe. That could be. You create a larger hole, you might have less trauma to.
The patient unfortunately died of COVID shortly after that, unrelated to the procedure, but we didn't get enough time to tell if there was a difference.
Good.
So hemolysis is something to think about as well, isn't it? I think there's a question from Philip's side of the room.
Yes, so we do have 2 last comments or questions, then a final vote, and then the closing remarks, just to let you know. Okay, please.
From your lecture, I saw the 4% procedure was aborted. So what's the cost of the procedure abortion?
I'm not aware of those because it's in the ENCIRCLE trial out of the 300
patient
patients.
selection or something else for abort the procedure?
I'm not aware of
thank you.
The specific reasons.
Hopefully to be determined or unveiled in due course. Final question.
Sorry, so just a quick question. So patients who have degenerative MR, so for example, chordal rupture, rupture of some primary chords, are they still feasible for the M3 procedure since we need to have a dock anchor there, or is there any concern about that?
Yes, the degenerative MR is an indication, and absolutely, yeah. Even
if there
chordal ruptures.
Yeah, but it can be a problem. I agree. On the medial side, if you have chordal rupture at the entering point, it's an exclusion criteria.
On the medial side.
On the medial
prolapse
side.
on the medial side. Yeah,
that's
Okay, so
as conditional fusion on the medial side, that creates a problem.
I made the rules, so I can break them. Another question.
Very short question. What is the real-world data on the screen failure rate?
For our center, 2 to 1.
2 to 1 for your center?
Yeah, at the moment.
In ENCIRCLE, it was 3 to 1.
Yeah.
And I guess we will get better and better understanding where it's worth to submit and screen and where it isn't. At that point in time, we submit 3 patients, we get 2 approved. So it's fairly recent, but it doesn't tell you the percentage of patients who were not considered at all, right? I mean, obviously, with none of these devices, we will ever be able to treat them all. That's just something we have to accept.
This is still a procedure in its early stage of diffusion, so.
Okay, last vote for you. Who is now interested in M3?
Nice.
Well done. Always. Good. Okay, then I have the pleasure of summarizing and closing off this wonderful session. I think we clearly learned that TEER might be called a leaflet therapy, but it's all about annuloplasty. On the tricuspid side, we have different options, whether it's sipping or clover. Most importantly, look at the anatomy, get an idea of how to achieve the best annuloplasty effect. Annuloplasty effect also matters on the left side for the mitral valve. The field of mitral interventions obviously got a lot of momentum and dynamics with the welcomed advent of a now approved transcatheter replacement system. I think it's really exciting and it's a privilege to be in the field. Many more things to understand. It will keep us busy in discussions, but also creating the evidence we need. But overall, I think it's a tremendous step forward that we finally have a replacement system. And not only this system, but in general, it fosters the idea of working together, surgery, cardiology, imaging, heart failure, post-procedural care. So the more complex these interventions get, the more important is that your team is ready for it. Thank you very much. I hope you enjoyed. Thank you very much for the excellent panel we had, for you for the moderation, and enjoy the rest of your day. Thank you.